Okay, great. Yeah, you can go ahead and start. And I think everybody knows who you are. I think you work with everybody so much. So
Right.
happy you can help with this talk because you're really the best one to give it, I think.
Yeah, thanks for letting me. And thanks everyone for joining us. So if we haven't met, I am Samaya. I'm one of the, or I am the AMS ID pharmacist. Today I wanted to talk about something we get a lot of questions about, and it's how do we prepare for a regulatory visit? How do we know we're ready for a visit? And how do we make sure we are meeting the Joint Commission, the CMS, the CDC, the IDSA, and all of the requirements? So I hope to have a lot of time at the end to have some discussion. I know a few of you on this call are leaders, so please feel free to share some of your experiences with surveys so that we can all learn. All right, and I think we all recognize the importance of an antimicrobial stewardship program and the importance of having a robust antimicrobial stewardship program. I wanted to share this new data from the CDC that said more than half of antibiotic prescribing for selected events in hospitals was not consistent with recommended prescribing practices. So this slide really shows some of the areas where we have inconsistencies with guidelines. 79% of the time with community-acquired pneumonia, so very high. Same with UTIs and inappropriate use of fluoroquinolones. This is a snapshot of the IDSA guidelines for implementing an antimicrobial stewardship program. I know we've gone through this before, so I won't spend any time on it. I just wanted to make sure we have it on here as a reminder, because this is eventually what helps us, one of the tools that help us in building our antimicrobial stewardship program. Again, the focus will be on regulatory requirements. So here I have just a very high summary of the different types of facilities and then the different requirements. So for an acute care hospital or a critical care hospital, the requirements are the same from Joint Commission under the same medication management standards. This is also having an AMS program is also a CMS condition of participation. And it is highlighted in the CDC core elements. For ambulatory care, they have different Joint Commission medication management standards. When it comes to CMS, this is under their MIPS and MACRA, so under reimbursement. And then there are specific CDC core elements for the ambulatory setting. I think we've also discussed this before, the CDC core elements. What I wanted to do was just to give a quick highlight of them and then kind of talk more about like the practical ways we can make sure we are implementing all of the core elements in our specific practice. So the first one is hospital leadership accountability. So I've divided this into like 3 main sections, and what we can do to make sure we're meeting this element is make sure we have a hospital AMS charter, make sure we outline and highlight our leadership support, whether it's having FTEs dedicated, whether it's just having the resources from MD stewardship. So having like financial, human, IT resources, all of those highlighted in our program. And then the third main component is making sure that our program leaders have opportunities to see what we are doing with our stewardship activities, what outcomes, what things we are tracking and reporting, and just making sure to do that regularly. The next element is accountability. Again, this highlights the importance of having AMS resources, and then appointing a leader and a co-leader to lead the antimicrobial stewardship program. The 2019 update really highlights the effectiveness and importance of having a physician and a pharmacist as a co-leader of an AMS program. Which highlights number 3, the pharmacy expertise. So having a pharmacist, ideally as a co-leader to lead all of the initiatives. So if your specific hospital doesn't have an ID trained pharmacist or someone who does AMS, you always have the resources of MD stewardship as well to make sure that you are meeting that core element. The next one is action, and this is a busy slide. And it's busy because this is what we're busy doing the majority of our day. This is the AMS review. How and do we track this? Do we document it? Where do we document it? Do we ensure that we are following those CDC guide, or I'm sorry, those IDSA guidelines of having prospective audit and feedback, of having pre-authorization, facility-specific treatment recommendations? How do we do that on our day-to-day? I know antibiotic timeouts, like a 48-hour review or a 72-hour review, was something that was always highlighted. It's still a very important intervention, but now it's made sure to be just an additional intervention to making sure you still do the prospective audit and then the pre-authorization. And the 2019 update emphasizes the importance of actions focused on specific indications for hospital antibiotic use. The one highlighted is lower respiratory tract infections, such as community-acquired pneumonia and urinary tract infections. Also, the update highlights the importance of having nurses, including nurses in some of these actions. This next slide we've seen before, but it makes sense that the 2019 updates would highlight us focusing some of our reviews on inappropriate prescribing in these specific areas. All right, so we do all that busy work with action. We're doing all our pre-authorization and prospective audit and feedback. We often forget to document all the work we're doing, but tracking and documenting is extremely important. So whether you document in your own specific EHR, Epic, if you have iVents or Cerner, or if you use the online iCloud document provided by MD Stewardship, it's very important that we track. Also with NHSN, there's two different things, AU and AR. The AU with the antibiotic utilization is the one most people are able to track. And then why do we track? We track so we can report, and so we can have trends, and so we can help identify areas for our antimicrobial stewardship program. But then where do we report? We talked about this before. You can report anywhere. If you have a P&T program, that's probably the easiest place to report, or an AMS meeting. And what are we going to report? We're going to report anything that we've tracked from our documentation, whether it's trends, days of therapy, antibiotic cost and utilization, anything you identify in your ministry. And then finally, education. So this is last but not least. Obviously, education is really important. MD Stewardship provides monthly webinars. I've created this to be a hyperlink if you'd like to go to those webinars. But also in the update, there is a highlight on education right there on the spot. So let's just say you're reviewing a case and you're like, I recommend to discontinue the fluoroquinolone because the patient has a Staph aureus bacteremia, and this is not guideline based, et cetera, et cetera. So that also counts as education, and it's real time. And the providers are then able to take it and use it for their next case. And then also the importance of including nursing. Nursing is always frontline with our patients, and they're able to provide a lot of that education. And this is just a summary from the CDC of the core elements that we have highlighted so far. Dr. Horn, I want to make sure you don't have anything to add.
Oh, no, I don't have anything to add. No.
All right. Okay, so you're like, okay, we've reviewed those core elements. We've seen these core elements. We've seen the IDSA guidelines. How do I know I'm doing everything I need to? And something I like to do is a gap analysis tool. So these are just my examples, but if you take the CDC core elements, so on the left, I've highlighted the 7 core elements, and you're like, where does my hospital stand and where do I want to be? So MD Stewardship is helping me meet all of these core elements, but I want to make sure that I'm optimizing that. So you have your hospital leadership commitment, you're at a 5-star. We're always striving to be a 5-star service, right? So I have leadership commitment, I have ID staff commitment, we're good there. And then as you go through the core elements, let's just say your pharmacy expertise, they're at a 4-star, you'd like to engage more of the frontline staff. Tracking, I know I gave This is just an example, but tracking and reporting, I gave 1 stars because that's something that's often forgotten. Like we said, we get busy, we're not sure what to track, we're not sure what to document. So you're like, when we're reflecting on my hospital, I'm at a 1 star, I'd really want to track and document more to get to a 5-star state. Education, I gave us a 5-star. You know, the majority of us have engagement with these webinars that help us to meet those elements. And then you're like, okay, so I've identified some areas for the core elements. What are some areas I need to identify from Joint Commission standards? So over here, I have highlighted the medication management standards from the Joint Commission. A lot of pharmacy leaders are probably very familiar with these, but they're very, very similar to everything we've discussed. So to have leaders helped us establish an antimicrobial stewardship as an organizational priority. Where do we stand? Where do we want to be? Are we educating staff? So one area where this is usually a gap is that they're educated once and it's forgotten. You know, in the pharmacy world, we can have competencies to make sure everyone is still comfortable with dosing, for example. So you're like, yeah, I think I have some opportunity in my hospital, so I'm going to do a 2-star and make sure we are more in line with our competencies, make sure that we include interdisciplinary groups into these webinars so that our nurses, our physicians also attend. And then the next EP4 in Joint Commission is having an antimicrobial stewardship multidisciplinary team. So does your hospital include pharmacy, infection prevention, infectious disease physicians, and microbiology lab? And you're like, yeah, we meet that. You know, our micro is involved. We discuss with our infectious disease consults. We feel pretty good. We have a 5-star here. And then how are we doing with the core elements? So that was the slide prior that we just discussed. You know, you're like, oh, maybe I'm doing really good with a few of them, but I'd like to optimize some, like reporting. So we're going to give us a 3-star. Do we have our own policies and procedures? For example, order sets. Do you have order sets that maybe need to be optimized or reviewed or updated? And then for the next 2, again, it's very similar to the CDC core elements. EP7 is the hospital collects, analyzes, and reports data on its antimicrobial stewardship program. So again, this often gets forgotten. It is a manual process. So there's always opportunities here to make sure we're tracking our data and reporting it and helping our hospital identify trends. And then what action are we taking on these opportunities? So just an example of a gap analysis tool. You don't have to make it a table. You don't have to use stars, but this is just something for me, I think is easy to see it graphically. Where am I and what things do I need to work on? There's, this is another way you do it, where you can line up your core elements from the CDC. You can line up all of the EP standards, the medication management standards from the Joint Commission, and then again, identify areas where you are, and then goals. You can use this to set goals. You know, I have ID involvement. I have some AMS pharmacists, but I'd like to train more of my frontline staff to understand stuff. Or I'd like to develop a new IV to PO policy for the hospital. So all of these are things that we can help in prepping for any kind of regulatory visit to make sure that we are meeting those standards and those requirements. All right, so we've done all this prep. We know we meet CDC guidelines. We know we meet IDSA recommendations. We know we've fulfilled all the Joint Commission medication standards, but often when the surveyor is there, there's a little bit of panic. What do I need to do? What do I need to show them? How do I prove that I actually have a really good AMS program, that it's a robust program? So what do I do? All right, so just some quick summaries on what we can do day of survey. Make sure you just explain the robust program. What am I doing on the day-to-day? What kind of prospective audit and feedback? What is my engagement with MD stewardship? Usually a daily call to an ID physician or an ID pharmacist that highlights our multidisciplinary work. So just explaining just the basics of the everyday work really will highlight your program. And then you can also show how our program meets standards and the core elements. So I'm going to go back a few slides here, like for example, showing them this, like we've identified all of the core elements, we've identified the Joint Commission standards, and then here's how we're meeting every specific recommendation. Making sure that during our survey, we involve our key stakeholders. Do we have our physician champions? Do we have our infection prevention team, for example, pharmacy, everybody? And then if you're asked for documentation, making sure we have regulatory department approval before providing some AMS documents. And I'll go into like what kinds of documents you might be asked for. Again, remember, surveyors are only here to ensure we are meeting compliance and that we're providing the best and safest patient care. So they're not here just to put us down or intimidate us. Again, what can I give them? Most hospital regulatory departments would want to approve any documents, even if they are AMS specific, before you give it to them. And again, discussing your day-to-day AMS work. Do you have any treatment pathways you follow? You know, for example, you can be like, when I identify a Staph aureus bacteremia, I know that I need to assess the patient for MSSA versus MRSA. I know that then I switch the therapy, then I recommend an echo, then I recommend discussion with ID, et cetera, et cetera. So do you have a pathway for anything that you can share with them? And then outlining some of the multidisciplinary work. Most of us have an antibiogram that we can share, and that highlights your work with the microbiology department. Do you have an infection prevention team, and are they submitting to NHSN? And if they are, do we have access to those reports? And then finally, and really importantly, just highlighting the pharmacy physician collaboration, the day-to-day work for AMS. And then when it comes to what reports to provide, just some 3 big bucket items, I guess. So do you have any trends? So we trended, you know, we documented, we trended that we could probably reduce our vancomycin use. And this is what we did. And then here's how that looks. Or we identified that we have a lot of hospital-related C. diff infections. Our IP team helped us to identify that. So we trended that, we put in XYZ intervention, and then here's how that looks. Okay, so that's trends, but do you have goals? So for example, you can be like, this year, we want to highlight some of our overuse of broad spectrum antimicrobials, and this is how we're tracking them. And then other things, easier metrics to track or show, are we tracking drug cost and tracking that appropriately? Are we tracking just basic interventions? One easy one is IV to PO conversion. So for an example of that would be, you can say this year we'd like to target more IV to PO interventions. We have a new policy in place. We've identified a high drug cost for our 100% bioavailable drugs where we can switch to orals. And then here's what our trend looks like for days of therapy. Just an example that you can provide. Another example here, you can be like, oh, look, we identified that our days of therapy for our broad spectrums is really high. One specific one we identified is cefepime, real overuse here. We wanted to track why that was, to be able to put in some kind of initiative. Another thing you can show is very easy. As long as we have documentation, we can just show like real high level what the types of interventions are that pharmacists are doing on the day-to-day. Are we broadening coverage? Are we adjusting doses to meet guidelines? Are we stopping duplicate coverage, etc.? So just like a real basic report of what types of things you are reporting and tracking. And then if you don't have those, do you have any program work you're working on? Do you have any policy specific to AMS that you are currently focusing on? So for example, are we starting an IV to PO policy? Most hospitals have pharmacy dosing protocols like GENT or Vanco, pharmacokinetics. So those are easy program type documents to share. And then One big one you can highlight is the multidisciplinary work. So we've already kind of touched on this. Do we have an antibiogram for microbiology that we can show our surveyor? Do we have any hospital-related infections that our infection prevention team is helping us track that we can show? Do we have anything with our physicians that we can provide newsletters, show webinars, any type of education, just as an example. So lots of different opportunities to provide reports, documents, all of that. In my resources, I added these as links, just so that if you're like, oh, I really just want to look up the Joint Commission Medication Management Standards, you can just click there and it takes you there. I'm hoping that it would be easier for you to see everything. Dr. Horn, I want to make sure I didn't miss anything that you wanted to touch on.
No, that was great. You know, I do want to emphasize to everybody that we do have documents and protocols, and we do help with that. So if there's anything you'd like the leadership documents or anything like that, or any protocols that you'd like to make or that you're interested in, you know, we'd be happy to send some protocols or example protocols, and you can modify it for your facility. You know, I think some places have found that very helpful, and I'm not sure if everybody knows that we help with that. So, you know, that's the only thing, you know, I wanted to emphasize, but are there any questions at all? If anyone has any questions, they can write it in the chat, or they can unmute themselves. But that was great. I think that really touched on everything. I think the documentation is really, you know, the action part. I think everyone has actions that they're taking, but the tracking and how to track is sometimes the question that we get. And usually we recommend not adding too much on. You know, if you're already tracking some things that can be used for the metrics, I think that would be a good thing to do. Samaya, are there some simple tracking things that you'd recommend as far as meeting that requirement, or how strict are they when they, you know, I think that everything kind of stopped during COVID, but you know, we're hearing that some facilities are getting questions about what they're doing and everything. And are you hearing about how strict they are, or what anything specific that they are looking for?
I don't know if this is just my unique example, but post-COVID, I have noticed that they're a little bit more lenient and understanding, but it's very good, like Dr. Horn is saying, when you're tracking, because if you're like, yeah, I do this every day, I track, I have these trends, and then they're like, where are they? You know, and then you're like, I just do it, you know? So then that's a really good way to be like, oh no, I track this, I trend it every day. Here's an example of a report I use to present to my P&T committee or my med exec group or anything like that. So that's just why tracking is really important, because otherwise it's just like, I do this, but like, where is it going? Or how do you know that your interventions are making a larger impact on patient care?
Okay, great. Yeah, if there aren't any questions, you know, you can always email your questions later to either of us. That'd be great, or contact us with, you know, anything you like. But I think that that was great. Thank you so much, Samaya.
Yeah, thank you, everyone.